prophylactic management. Prophylactic management is, there are patients, many of our high-risk patients are like living petri dishes. Patients who are immunosuppressed, cancer patients on chemotherapy, HIV infection, patients on steroid administration, patients with complicated abdominal surgical procedures, widespread use of implanted devices, the use of broad-spectrum antibiotics, particularly the carbapenems, total parenteral nutrition, diabetes, multiple sites of colonization, burns, and patients on long-term Foley's catheters. These are patients who are predisposed to developing these infections. So, when we get a patient who is neutropenic, we have given him chemotherapy, he is neutropenic. He doesn't have any other signs of infection. There is a role for starting him on antifungal therapy, and that is called prophylaxis, prophylactic therapy. He doesn't have signs of infection, but he has the, he has the environment. He's in an ICU, he's neutropenic, so we put him on antifungals straight away without any signs, trying to prevent fungal infections. This is what we mean by prophylactic therapy. And there are certain guidelines for this. I think you will be covering these guidelines. So I will just give those as Dr. Sarkar will be covering these guidelines.
So actually, I will not go to all the guidelines. I will just focus on the latest guidelines. So you can cover.
So basically, all we need to know is that for different situations, we have guidelines for the use of antifungal prophylaxis. For example, when we are dealing with patients of chemotherapy-induced neutropenia, so we can use fluconazole, posaconazole, anidulafungin, caspofungin as prophylactics. So these are for stem cell transplants. We have another set of we have a set of antifungal agents under guidelines which we can use. But what are the consequences of prophylaxis? We may be actually avoiding some dangerous infections, but there are consequences. First of all, as we use more, the most commonly used prophylactic agent would be the azoles, fluconazole for example. And as we use more and more fluconazole in the prophylactic setting, we are definitely going to get more and more resistant bugs in our ICUs. So that is not a good scene, and we will get more and more of glabrata, cruci, fusarium, and these are organisms which are not really very sensitive to most of them, and as I showed you in the earlier chart, they carry a very high mortality. So the more we use of prophylactic, the more we risk these kind of bugs emerging. Now this is a newer trend which has started, it's not very common, that is preemptive therapy. I will just illustrate it by an example. For example, there are patients of liver transplants. Now these are patients who are immunosuppressed, they take immunosuppressive agents, and they are quite prone to develop fungal infections, systemic fungal infections. Now we cannot keep them on antifungal prophylaxis for 1 year, 2 years at a stretch. So what do? Do we wait for them to get these life-threatening infections before we actually start them on empirical therapy? So we try to find a middle path, and some studies have been carried out. For example, you keep measuring the 1,3-beta-D-glucan levels at regular intervals, and the moment you feel that it crosses 40 picograms per milliliter, we put them on antifungal agents. So we are actually looking at a situation where we are trying to see whether this patient is now on the verge of developing a florid fungal infection, a clinically symptomatic fungal infection. There are others who have tried out with the colonization scores. They actually look at the colonization levels of candida in the body, and if it crosses 4, then they generally would start them on antifungals. So it's not prophylaxis. They are looking for hints at which, or you can even do the galactomannan assays. Patient may have fever as well, but you look for, there is no blood culture, nothing, but you look for galactomannan, and it generally comes positive about 5 to 8 days before clinical symptoms. So this is the situation if we start antifungal drugs. We are not giving them to all patients, but we are using them in patients who have certain positive signs, who have certain positive results like 1,3-beta-D-glucan, galactomannan, or the colonization index, and then we start antifungals for them. This is known as preemptive therapy. It is trying to prevent the excessive use of antifungals in the prophylactic setting. But this is an evolving area. It is not as yet well established. It needs more validation, but it is being tried. And this is what we all practice. I think this is the most common use of antifungals in, the world over. and so too is it in our practice, where we use it empirically. So you have a patient who is having fever. He's already been started on broad spectrum antibiotics. As I told you, he is having certain risk factors, and I just referred to the Candida scoring system. So we have a scoring system for that, and if we feel that this is a patient who could possibly be harboring an active systemic fungal infection, then we put him on systemic antifungals. And so this is known as empirical treatment. We do not have the culture reports, but there is an environment, there is a Candida scoring system which is actually allowing us to put the patient on antifungals empirically. But this is a patient who is diseased, who has symptoms. And we need to, of course, select the appropriate antifungal agent depending on a number of factors. Now, this is the Candida score, which is very commonly used. I have certain personal reservations about it, but then this is one of them that we have, where you score 1 for total parenteral nutrition, 1 for abdominal surgery, 1 for multifocal colonization, 2 for clinically severe sepsis, and the cutoff value is about 2.5. So if the score is greater than 2.5, then there is about an 8 times chance that he is going to have fungal infections. So on the basis of that, you can start the antifungal therapy empirically. Of course, there are certain general principles like removing the central line, removing or changing the Foley stop, empirical antibiotics, and of course tight sugar control, stop steroids if possible. And how long does one treat these infections? We generally treat these infections for about 2 weeks after the last negative blood culture. How do we select the agent for the treatment of candidemia? Well, if there is a history of recent azole exposure, patient has received the azoles in prophylaxis and he still develops fever, and there is a possibility that this might be due to fungal origin, obviously we are not going to reuse azoles. We will go on to the echinocandins or liposomal amphotericin B. There is a history of intolerance to an agent, obviously we'll go on to some other ones, and it depends as to the severity of illness and whether the patient is neutropenic or non-neutropenic. There are evidences to there are guidelines which will tell us which drugs to use in neutropenic patients, which drugs to use in non-neutropenic patients, etc. And it depends on the severity of the illness as well. If the patient is not very ill, one can try with the azoles. But if the patient is, but if the patient is very seriously ill, then we have to cover the entire candida range, and it would be better that we would try him out with an echinocandin, because echinocandins generally would cover the entire range of candida species. It's just parapsilosis which has a little plus minus kind of sensitivity, but apart from that, they do cover almost all the other candida species. Whereas the azoles, as you know, will not cover glabrata, crusade, and some others. Even liposomal amphotericin B is not very good with Guillermondi and Lusitania. So this is the empirical treatment guidelines, as you can see. This is what I just mentioned. Fluconazole or echinocandin in moderate to severe illness or with prior exposure to azoles, it's echinocandins, whereas with less severely ill patients with no prior exposure to azoles, we can use fluconazole. It's much cheaper. And for the alternatives, we do have liposomal amphotericin B. We can use conventional amphotericin B, but then it has a lot of problems. It's nephrotoxic. It has a lot of infusion reactions. And finally, it is targeted therapy. Now, this is of course ideal, but very often we do not have the option